thank you to the Texila University and all other people who give me the opportunity to sharing my views. I am the Dr. Jayesh Thakrar. I am from the India. Basically, I am the anesthesiologist and the international pain specialist. And I presented my today's studies about the efficacy of the sympathetic radiofrequency in complex regional pain syndrome 1. Stellate ganglion block versus T2T3 sympathetic block. The upper limb complex regional pain syndrome is one of the inflammatory and neuropathic pain conditions after the injury due to involvement of autonomic nervous system. It is mainly diagnosed by the International Association of Study of Pain criteria and the Budapest criteria. That includes sensory changes, motor changes, vasomotor changes and pseudomotor changes. We take the one criteria from all four areas and then we label as a complex regional pain syndromes. After taking the histories, giving the examination of the every patient, taking the pain history, particularly visual analogous score, and we recorded in the history form. And after that pain score, we give the first conservative trial for the pain management. The conservative pain management includes the pharmacological therapy, mainly anti-conversion group of the drug, that is in gabapentin and pregabalin. And another, we can add axiom drug like the antidepressant drug like amitriptyline and gives the weak opioids in all patients. So we give the combination of, we give the one gabapentin drug, one is the amitriptyline and other is the tramadol. It is the patient body that we adjust the dose according to the patient's pain intensity. If the patient not responding to the conservative trial for the 6 weeks, then we consider this patient as an chronic pain and we go for some international pain block, that is a sympathetic block, who not respond to pharmacological management. Not a single method is effective in pain management in complex regional pain syndrome type 1. Evidence is suggested sympathetic block, that is the stellate ganglion block and T2T3 sympathetic block gives the effective pain relief in upper limb complex regional pain syndrome. Those patients who will not respond to conservative pain management. In upper limb, the innervations is taken by the sympathetic innervation by the two blocks. One is the stellate ganglion block that is situated between the C7 level and another is the T2T3 level. In adaptive pain relief after the satisfactory stellate ganglion block, sometimes patient not respond to the pain, gives a good relief because of the T2T3 sympathetic block, because of some Kunzino anomalies. The Kunzino anomaly is that nerve that supplies the upper limb that bypass the stellate ganglion sympathetic chain and get innervated through the T2T3 sympathetic. So many patients who not respond to the sympathetic stellate ganglion block can very well give a good pain relief after injecting into the T2T3 bone. After doing the diagnostic with local anesthetic, we plan for the radiofrequency thermocoagulation in the both groups for the long-term pain relief, and after the pain relief, we have considered that there is a decrease in dose of the analgesic drug. So, what's the problem? So, complex regional pain syndrome, it is a neuropathic pain condition and mediated by the autonomic nervous system, and thus either it is sympathetic mediated pain or the sympathetic intermediate pain. There is two entities there. So, those patients who have sympathetic mediated pain in CRPS are very well respond to the sympathetic ganglion block. But those who are sympathetic independent, they are not respond to the any kind of the modalities, and that those patients we consider as sympathetic independent pain, and these require a multimodal approach for the pain management. So, not a single method is effective for pain management, so multidisciplinary approach is required, including physiotherapy. Chance of the false positive and negative block because of the pain is subjective, and complexity of the pain phenomena and the pain pathway. Pre-existing or associated neuropathic pain or neuropathic pain influences the result. And diagnosis for CRPS is the purely on the patient's history, examination and diagnostic sympathetic block, and mainly by the IASP and the Budapest criteria. So in my study, I have evaluated 15 patients from the period from the July 2015 to December 2015 with the diagnosis of the complex regional pain syndrome type 1 in one head based on the International Association study of the pain criteria, and 7 very conservative pain management. That is, we give on the patient we give the conservative pharmacological management more than 6 weeks, and the pain score is more than 4 by 10. Although 15 patients were given diagnostic stellate ganglion block initially first. Out of 15, 8 patients was given positive result. That means his or her last score was decreased more than 50%, and those patients we are considered the candidates of the radiofrequency for the long-term pain relief. Out of 15, 7 patients were not much pain relief after the stellate ganglion block. So we consider these patients as a congenital anomalies, and we give the second diagnostic block in form of the T2 T3 diagnostic block. Out of 7 patients, 3 were positive diagnostic block, and that we consider as a plan for the radiofrequency for the long-term pain relief. And 4 they not respond to any kind of the pain relief after the stellate ganglion block and the T2 T3 block. So these patients we consider as a sympathetic independent pain. Among the 15 patients, 8 patients were from the right hand and the 7 patients were left from complex regional pain syndrome type 1. 9 were female and 6 were male. Age between all the patients between 18 to 5 years. Conditions that lead to the CRPS 1 were fracture lower and radius, hand trauma, metacarpal fracture, soft tissue excision, carpal tunnel syndrome, and the crush injury hand. All patients were pain score initially visual and score between the 7 to 10 out of 10. And all the patients who we give pharmacological pain management initially, tablet gabapentin 400 to 600 mg, tablet amitriptyline 25 mg, and the tablet tramadol 150 mg per day. After diagnostic stellate ganglion block, 8 patients were positive result, and we give a radiofrequency to these 8 patients stellate ganglion block, and the post radiofrequency pain score was 3 to 4. The 7 persons who are not responding to stellate ganglion block was posted for the T2 T3 sympathetic block, and out of 7, the 3 persons was positive, and we shifted them for the radiofrequency thermocoagulation T2 T3 block. And the post radiofrequency pain score was 3. 4 patients had negative results after giving the both T2 T3 and the stellate ganglion block, and that considered as a sympathetic independent pain. And this patient was excluded from my study, and we provide some another modalities for the pain management. Doses of the analgesic drugs were reduced in both groups after the radiofrequency. The tablet gabapentin was reduced from 400 to 600 to from the 400 to 600 mg to 100 to 200 mg. The amitriptyline, some patients were stopped. We stopped the amitriptyline. Some patients required the 10 mg dose from the 25 mg. And tramadol was reduced from the 150 mg to 50 mg per day. So that radiofrequency thermocoagulation, the stellate ganglion block and the T2 T3 sympathetic block was significantly reduced the pain, visual anomalous score, and reduced analgesic drug doses and improved quality of the life of the patient. These are the references. So my conclusion is the study showed that there is a chance of the heat-adapted block after the satisfactory stellate ganglion block due to the Kundinou, and giving T2 T3 sympathetic block among these patients gives good relief to such patients. Radiofrequency thermocoagulation provides the long-term pain relief in both groups and improved quality of the life. Pain score, visual level score, that is, and doses of the analgesic drugs were reduced after the radiofrequency. Though visual movement is improved clinically after the radiofrequency in both groups, but requires a separate study design. Long-term follow-up and the larger sample size required for the better outcome of the studies. Sympathetic independent pain, patient that is negative result after the stellate ganglion block and the T2 T3 sympathetic block require the different modalities of the pain management. Along with radiofrequency, multimodal pain management improves the quality of the life of the patient. Thank you.